There are some things that I want you to learn about what pain is and what pain is not. And I start with this statement here because truly the challenge of understanding pain and getting control of pain really rests in your brain. So as you all know, pain is a big issue. And I want you to know that sources of pain come from multiple body parts, but common areas include the long bones, especially in your legs, arms, and other structures. The first thing that I want you to understand is that pain is not just a noxious stimulus coming from a body part. Pain is an experience in your brain, all right? Your leg or your arm that may send a pain signal is not the structure that's interpreting the pain, it's your brain. And we're going to talk more about that. The other important point that I want you to know at the outset is that your pain is real. It's not made up. This is an experience of your brain. So as we understand more about what pain is, as I mentioned to you, pain is interpreted in many areas of your brain, and I'm going to show you a picture of that. But these areas in your brain may not be directly involved in the generation of the pain signal that may have started in your leg. These other brain areas include centers in your brain that help control the fear response, other feelings, and they have an opportunity to add their input, which can change the perception of the pain. So when these other areas of the brain get activated, and as they add their input, that can change the perception of pain and add a component to pain that we all know, and that's known as suffering. And that can make the pain much worse. What I want to say about these areas is that as they add their input, they act like amplifiers in an electrical circuit. And that's the analogy that I want to use. So I'm sorry for any of the non-technical folks in the audience, but I know we have quite a few. So here's a simple electrical circuit here. I hope you can all see this. If you look on the left side, you'll see that there's a pain signal coming from an area of your body like your bone. That is a real signal. And then it travels through your spinal cord, it comes up into your brain, it hits a relay station, and the signals then get sent out to all of these other centers. Each of these centers get to add their unique input. And as they do, they modulate the signal. They can amplify the signal. So what's coming out of each of those amplifiers is now a larger signal. All of these different signals now are summing and going to the very highest centers of your brain. And that's where the final interpretation takes place and can result in you perceiving the pain as much worse, especially when there's a suffering component added to it. If we can go to the next one. So here is a mapping that was done in a study in 2018, and note that 6 years old, more centers have been found. But look at the number of centers in your brain that have a role in you perceiving and interpreting pain. So as I mentioned, some of these centers act like amplifiers and they increase the pain. So think of having a radio and you're turning the volume up and up, it's getting louder and louder. The good news here is that some of these centers can also de-amplify the pain. They can suppress the pain. They can change the meaning of the pain. What we want you to know is that you can, through the power of your mind, modulate this pain perception. Another important issue with pain in ECD is the development of chronic pain. Acute pain becomes chronic when it persists and when other factors are in place. And those other factors you can see in the pain cycle on your right. Factors such as lack of sleep, anger, frustration, anxiety, depression, and so forth. All these other factors then sum together and they put the person into this vicious cycle. And as this continues, the cycle actually reinforces itself and it becomes harder to break. But you can break this pain cycle. And I have seen people do this. So how do we conquer pain, right? The first step is tell your doctor that you're having pain, all right? Please don't say that nothing is wrong when it is, because sometimes we can see it on your face, all right? The other thing is, please don't try to tough out the pain that you feel you have to tough out the pain, because that only reinforces the pain cycle and makes it even harder, all right? I've listed some medications here, which I won't have time to go over, but I just wanted to say that the antidepressants on the right can not only be helpful with pain, but some of the mood disturbances, and so that they're able to address multiple issues that come along with the pain at the same time. Okay, now I want to talk about a touchy subject, but one that I think is important, because there are times when someone's pain has gotten to the point where they simply cannot function. I've seen people not really being able to get up out of a wheelchair. In circumstances like that, there is a role for narcotic medications. I know the country has been having trouble with an opioid epidemic, but narcotic medications are effective pain control agents, and they can be used to get pain under control while you are working on other strategies to control your pain. So think of this class of medications as a bridge, all right? I have also found that they are very helpful for people who have pain at night, often because they'll complain of bone pain and they can't sleep. And the opioids will help by relaxing the person, reducing the pain, and help them sleep. Now let's turn to fatigue. This is another big problem. And I have seen people whose fatigue is so severe that I've described it as bone crushing, where people feel like they just can't move. Now, there are multiple causes, and first and foremost, you have to look for the medical causes, right? So these are hormone issues, or as we have seen, dysfunction of the heart, lungs, kidneys. These things have to be checked first. But besides that, there are other common drivers such as uncontrolled pain, insomnia, medication side effects, having been inactive for a long time. Like I said about pain, your fatigue is real, all right? It's not something that you're making up. So, beating fatigue, I would like to say that there's good news that the medication-induced fatigue can sometimes lessen as your body gets used to the drug. But if not, there's treatments for that. I want to emphasize again that you need to treat the medical effects of fatigue first, because the treatment of those issues will go a long way to beating the fatigue. Paradoxically, actually, regular exercise reduces fatigue. But at first, you may feel more tired because you have been inactive for so long. Now, like I mentioned, in certain situations with pain, there are times when someone's fatigue is so severe that they can't do the things that we need them to do, like rehab. In circumstances like that, prescription stimulants can be helpful, all right? They've been shown to be helpful in people who have fatigue related to cancer, and I've certainly have used them for that purpose, but not everyone is a candidate for this. So I need you to see your doctors. And I put some names up here on the board, and I just don't have time to get into them, but we can certainly discuss them later. Now, I think the most common cause of chronic fatigue in people whose ECD is under treatment is insomnia. And I've spoken with many of you, including these couple of days, and you have all said yes to that. This is a crucial part of beating fatigue, and it takes time. It's a coordinated effort between you, your family, and the physicians. Also, it's frustrating at first because you find yourself lying in bed and not being able to sleep, and your mind is spinning, and it's easy to give up too soon. So you have to stick with the plan, all right? Medications are sometimes necessary for that. So here I am again saying exercise, right? Exercise is an excellent way to reduce fatigue. It actually builds energy levels over time. Walking is great, but that's not possible for some. So you can ride a stationary bike, use an arm bike, use a hoist to get in and out of a pool, or if you're sitting in the chair, you can move your arms and legs in a chair. One other thing that I want to say is that you need to learn how to manage your everyday bucket of available energy. I commonly hear people say that when they have a good day, they have all these things that they need to get done, and they go great guns and they overdo it, and then they crash for another 3 or 4 days, only to fall behind again, and then have to wait for the day that they feel good, and then the cycle continues on like that. So as we move into the finish line here, I want to say that exercise is the single best intervention to dealing with this chronic pain and fatigue, all right? But it's something that you need to do regularly. But multiple studies have shown that exercise beats medication. I also want to warn you that when you start a program and you've been inactive for a long time, joint structures which haven't been used, they shorten and they get tight. So when you first start to move around again, they hurt. That doesn't mean that you're doing damage. It just means that you're stretching tissues, just like when you have a tight hamstring and you first try to stretch that, it hurts. So if you're having pain and you're trying to get back into a program, it's a good idea to take a medication beforehand, all right? I think meditation is an excellent way to try to reduce the pain, but it takes practice and you have to keep at it. It's especially effective when you add the breathing to it, and I've known patients who have reduced their pain by a third without medication. So my time is up, so I'm going to leave you with this final image. We can get this to play, hopefully. Oh, it didn't work. All right. Oh, so I wanted to show you that, but it didn't work here. And I wanted to thank everyone who's made this work possible. Thank you.
Time for questions. I started taking gabapentin originally for neuropathy in my feet because I had taken Taxol years ago, and then the ECD treatment caused neuropathy. But now I find my neuropathy is down because my drug therapy is down. When I take gabapentin in the evening, if my whole body's hurt in the evening, I take gabapentin. It totally helps my whole body pain, and it makes me more productive. I don't just collapse on the sofa.
I just want to be clear. You said that when you take that gabapentin, you feel better?
Much better.
Okay, good. Well, certainly it's been helpful for the type of pain that you mentioned for nerve pain, but it also has other effects too. And some of that could be some mood enhancing of effects because of the chemical messenger systems that it works on in the brain.
So what do you think of long-term gabapentin though? How harmful is that?
Okay, so that's a great question, and it's one that's been debated for a long time. I want to tell you that personally, I've seen people who have been on gabapentin for more than a decade, and and even longer than that, and they've been fine. Now, like any drug, it has side effects, and you use the minimum amount of drug that's effective to reach the objective, right? And then you monitor yourself for side effects. But once again, I've seen people on that, even at a high dose, for years and years, and they've not had any side effects to it. So if you want to talk more, we can talk about the dose and any side effects you've experienced. But I think someone had a question. You want to say, Jason?
Yeah. I've been on gabapentin, which is also called Neurontin, for many years, only 300. You can go up to what, 1,400?
You can go beyond that.
I do 300 at night. I don't find, I have no side effects, except if I forget to take it at about 2 or 3 in the morning when I'm wide awake. I thought, oh, I haven't taken my gabapentin. One neurologist, he thought I should go up. I did not. He wanted me to go up to 400. I stayed at 300 once a day in the evening.
I appreciated your presentation, Kevin, especially the cycle that amplifies the degree, some people experience pain. And one of the things you mentioned is especially when suffering is involved. And it's interesting because there was a book written long ago, I think Freud had talked about the difference between mourning and melancholia. Yeah. With both you get sadness, but with melancholia, you get feelings of self-reproach. Yeah. And I think that suffering thing, and that's the thing where I feel like some of the antidepressants can help in terms of it, kind of reinforcing the trash talk of yourself, that type of thing, which just amplifies more and more. So it becomes a vicious cycle.
Yeah, and the conference organizers and I have decided that I'll give a webinar where we can talk more about that. There is a lot of suffering in this because people have been disabled by this. And in our minds, what we have going around and around is, how did this happen to me. I have this strange, rare disease, and am I ever going to get better? What's going to happen to me? What about my mortgage? How am I going to pay these expensive medical bills? What about my marriage, my kids? So as I showed you the picture, you have all these other centers in your brain that are adding their input, and that's summing into what the final pain signals will be as they reach the very highest centers of our brain. And that's where the final interpretation takes place. And that final interpretation can very much include suffering, and that sensitizes the brain to the pain signal that started down here. Remember, you do not perceive and interpret pain here, it's up here, right? And all these other centers are going to add their input. The good news is that you can use the power of your mind to also modulate the signal, right? So as the amplifiers turn that signal up, you can use other brain centers to de-amplify the signal. That takes practice, but I've seen people be able to do this and come way down on medication doses.
What is Mobic?
Mobic is a selective non-steroidal anti-inflammatory drug. It, like other medications in that class, had been thought to be safer than the older non-steroidal anti-inflammatory drugs. And they work very well for musculoskeletal types pain. And I've known people with ECD who've used them. So it can be used, and I'd be happy to talk to you about that a little bit more. Does any other, I just want to say one more thing before we end. And that is, we all know that we've been up at night and we stubbed our foot and it hurts like hell, right? That's pain, that's acute pain, and it hurts, and it goes right up through the relay station in your brain, and it goes up there, and you're cursing yourself for what you did. But then the pain subsides. The other areas of the brain are not adding the input into that event that just took place. Pain is a neurophysiological event. But when you have pain, like you do to ECD, and all the other things that are swirling around in your life, which only some of which I've just described, that changes the fundamental quality, not just the amplitude of the pain. It changes what the pain signal means when it gets to the highest centers of the brain. There's physical pain and there's psychological pain. Those two things can come together. That creates suffering that sensitizes the brain to the original signal coming from your leg, all right?